Hello, and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP examinations. We are two junior doctors based in the UK who have successfully passed all three parts of the MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic. Psoriatic arthritis, which is under the section of rheumatology. So you will recall that we talked about axial spondyloarthritis in our previous episode, and psoriatic arthritis is the second condition that come underneath the seronegative spondyloarthropathies, all of which are HLA-B27 associated. The other three that are under this section, as you can see, are reactive arthritis, enteropathic arthritis, and maybe undifferentiated spondyloarthritis. So, what is psoriatic arthritis? It's an arthritis that's in about 20 to 30% of cases are associated with psoriasis. However, it's very important to note that it can indeed happen in the absence of skin disease. Okay, so as for the epidemiology of it, it affects males and females equally. And as I discussed earlier, you have on average about 20 to 30% of patients with psoriasis will develop psoriatic arthritis. It can sometimes, the arthritis can precede psoriasis in about 1 in 6 cases. Or it can simultaneously have an onset in about 15% of cases. As many other autoimmune conditions, it is more common in Caucasians than other ethnic groups. In terms of patterns of the disease, there are 5 different subtypes. The most common type that you may frequently encounter in clinical practice is the polyarthritis, which very frequently can mimic rheumatoid arthritis. It can present in about 15 to 20% of cases as an asymmetric oligo arthritis, followed by arthritis mutilans in about 5%, and then really the last two, which are the distal interpharyngeal joint predominance and the axial involvement, are about 2 to 5% of cases that are quite rare. So let's talk about signs and symptoms. This can be very helpful if you encounter this case as part of your Station 5, for instance, in your PACES exam. Frequently, patients will complain of asymmetrical joint swelling, and as I discussed, about 20 to 30% of cases will have associated psoriasis. Nail changes such as nail pitting and oncholysis are quite common in this condition, and I'm sure as many of you remember from your medical school, dactylitis or sausage finger is something that is frequently mentioned in textbooks. If this is a case of an arthritis mutilans. The characteristic or the buzzword that they may describe comes test day, it will be telescoping fingers. You can have paravertebral calcifications, and as I mentioned earlier, maybe the first presentation of psoriasis, as in the arthritis can precede psoriasis. So these are two of the most commonly associated nail changes with psoriatic arthritis, as you can see. On the left hand side of the screen you have nail pitting, which if you pay close attention you see very tiny small indentations on this patient's nails, and on the right hand side you have oncholysis, which are the whitening at the nail tips that are quite nicely demonstrated on the picture. Caspar classification is what we use frequently to help you with classification of psoriatic arthritis. I think it would be quite important to know what sort of factors are included in the Caspar, because if you have a memory of these, you can easily target your questions in your Station 5 or your history towards these. So you would be asking about any obvious history of psoriasis, either current or in the past, or even any family history of psoriasis. You would be asking for any nail changes that we discussed earlier. Having a negative rheumatoid factor would actually give you 1 positive mark in the Caspar, because remember the other possible differential for the condition that frequently present as a psoriatic arthritis would be rheumatoid arthritis. Having dactylitis either in the past or currently will give you a mark, and then finally if you have any X-ray changes such as newborn formation would also count for 1 mark. Scores more than 3 points or more has about 99% specificity and 92% sensitivity for psoriatic arthritis. Okay, so now let's talk about the investigations that you may want to consider in someone who is presenting to you as query psoriatic arthritis. Like many other rheumatological conditions, you may want to do your ESR and CRP, which importantly may be normal in this condition. You might see a normochromic anemia as an anemia of chronic disease, which would be an important factor to pick up. You may see high uric acid levels in this condition in about 20% of cases, and as we discussed earlier, about quarter of the cases will have HLA-B27 positive serum marker in their blood. And if you were to do a joint aspiration and analyze the synovial fluid in a patient with psoriatic arthritis, you will see an inflammatory fluid with neutrophils. So, in terms of the imaging that is frequently done, X-rays are what's most frequently used in clinical practice, and I think having an understanding of the changes that can happen in an X-ray, it can again serves you well when it comes to test day. So quite a majority, about 67 to 70% of cases, will have X-ray changes. The most common change that can happen in a case of psoriatic arthritis by about a half would be erosions. Remember, it's very frequently asymmetric changes, and that's the hallmark of the disease, and the DIP joint is frequently involved. Pencil cup deformity is what can come in as a multiple choice question, so it would be quite important to recognize that it's linked with arthritis mutilans. Okay, so in terms of the scoring systems that we use frequently in clinics for assessment of patients with psoriatic arthritis, we thought that it would be a good idea for you to be familiar with these, at least for with the name of them. So PSOC is what we normally use to measure the anti-inflammatory response and to basically find out how well controlled someone's disease is. And PASI is what we use to measure skin involvements. By all means, feel free to Google them in more details to find out more about them, but we thought it would be beyond the scope of this episode to discuss these in details. So in terms of management of patients with psoriatic arthritis, like many other conditions in the UK that are chronic, psoriatic arthritis also gets managed through the MDT with a special focus on physiotherapy and home exercises. Patients with psoriatic arthritis are ideally managed in a joint dermatology and rheumatology clinic. In terms of the medications that you can use to manage the disease, you would be employing your NSAIDs to help with the pain, and then your DMARDs or disease modifying drugs such as methotrexate or sulfasalazine are the first line that are recommended to manage the disease. And if the patient's disease is not managed with DMARDs in the case of psoriatic arthritis, the next line of therapy that you can consider moving up to would be your anti-TNF drugs. Most of you would be familiar with at least most of these. However, just as a recap, these are drugs such as adalimumab, certolizumab, etanercept, golimumab, and infliximab. If your psoriatic arthritis is still not managed despite trial of DMARDs and anti-TNF drugs, you can consider these biologic agents that we're going to discuss. It would be important to be familiar with the pharmacology of these drugs because very frequently, especially in MCQs for your part 1 and part 2 written MRCP exams, these can be tested. These drugs are IL-17 inhibitors such as secukinumab, ixekizumab, IL-12/23 inhibitor such as ustekinumab, PDE4 inhibitor such as apremilast, CTLA4 inhibitor such as abatacept, and finally JAK inhibitors that are quite recent in the market, such as tofacitinib and upadacitinib. Now let's do some questions. So question 1 is, which of the patterns of the joint involvement are not typical of psoriatic arthritis? A. Arthritis mutilans. B. DIP joint predominance. C. Symmetrical sacroiliitis. D. Polyarthritis, mimic of rheumatoid arthritis. E. Asymmetric oligoarthritis. If you remember, we discussed in the first few slides that asymmetric sacroiliitis is not really associated with psoriatic arthritis, whereas the options A, B, D, and E are quite typical of the disease. Question 2. Which of the following is a typical clinical feature seen on examination of the hands in a patient with psoriatic arthritis? A. Dactylitis. B. Boutonniere's deformity. C. Heberden's nodes. D. Jacob's arthropathy. E. Z-Tom deformity. So if you recall from our first few slides when we talked about signs and symptoms of psoriatic arthritis, you will recall that the correct answer in here is going to be dactylitis or sausage finger, as is frequently described in textbooks. Options B, C, D, and E are all findings of other rheumatological conditions and arthritides that have either already been covered in our previous episodes or will be covered in our future episodes to follow. Question 3. Which of the following drugs is not licensed for the treatment of psoriatic arthritis? A. Infliximab. B. Apremilast. C. Upadacitinib. D. Baricitinib. E. Secukinumab. As you can see, this is asking you about refractory management options for psoriatic arthritis. And if you remember correctly, option D, or baricitinib, is currently not licensed for refractory cases of psoriatic arthritis as a biologic agent. Okay, and that's it for today's episode. Thank you so much for listening. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure that you don't miss out on our next episode. Let us know in the comment which episode you would like to hear in the future. See you in our next episode.